adults as well as child. It was 2 years or 3 years of lockdown, not going to school, pressure of online, it's taking a toll on them. We are seeing lichen planus kind of reactions. Reticular, erosive. Again, the gold standard in management of lichen planus is clinically, if the patient, adult or the kid is asymptomatic, don't treat. Only if the patient is symptomatic, you treat. Otherwise, just keep the patient informed, observe once in 3 months or 4 months how things are taking a turn. The second thing, I know our president is an orthodontist, he might not like me to make this statement. Literature, I have seen 13 cases so far, post-orthodontic or during orthodontic treatment, allergy to nickel titanium. It's established, not everybody get it. So we have seen cases with orthodontic treatment allergic to nickel titanium alloys or wires, what you call it as a lichenoid reaction. So lichen planus can occur in children also. This case just came to our hospital about 15 days back. This boy is 14 years old. For the past 7 years, he has been having repeated ulcerations. Ulcers come, vesicles come, it breaks, it forms. There is no permanent disappearance. Intensity decreases. He has seen all patients, dermatologists, oncologists. If you look at the lip, there is a pigmentation. Can you see a fine white keratotic line or an area here? Again, depapillation of the tongue with irregular ulcerations and burning sensations. Bilaterally in the buccal mucosa, again patch with areas of reticulation, especially in the vestibule. Dystrophic nails, discolored nails, and eruptions on the skin. Dermatologist has diagnosed it as lichen planus. And treatment with steroids, Visolol, for almost 3-4 years, but no cure. But we are suspecting that this could be not just lichen planus. Lichen planus is tip of the iceberg. We are looking at a deeper picture, whether it could be a condition called as disc keratosis congenita, which has cutaneous and oral lichen planus or leukoplakia with ulcerations and vesiculations. But the danger of this condition, by the time the kid is 20 or 25, he will develop hematological malignancy. So we have done the bloods. Unfortunately, hemoglobin is very, very less. So there is a hematological parameter which is involved. This kid's hemoglobin is only RBC is only 2.5, which the physicians have not taken a care to address. They were thinking it's just lichen planus. But according to me, as of now, I don't know how it is. It just came 14 days back, we are still following it. I thought, have an open eye. Lichen planus could be a tip of the iceberg of something which is going to explode in the near future. Finally, verruca vulgaris or oral wart or papillomas. Very common because if there is a genital wart, the kid touches it with it and then touches the mouth, you have this kind of cauliflower-like appearance. You will have to be careful, it can spread, so the treatment is just a cryosurgery or you surgically excise it. Abroad, yes, any kid till about 18 years has to mandatorily take the HPV vaccination. So it's coming for us also, kids need to be vaccinated with HPV. So these are the common cases what I wanted to show. So finally, I conclude. We have seen mucosal lesions, we have seen pharmacotherapy. Do children get temporomandibular joint disorders? Yes. Because of the parafunctional habits, trauma, microtrauma or a macro trauma, malocclusion, the debate continues whether Malocclusion is a cause of TMD, but evidence-based doesn't suggest malocclusion as the cause for TMD, but you cannot rule out systemic factors like an idiopathic juvenile arthritis can affect children also. So you need to do a thorough examination of the temporomandibular joint, just like how you do it in adults. The mouth opening, the lateral jaw movements are about 8 mm on either side. Palpate all the 4 mastigatory muscles, masseter, temporalis, lateral pterygoid. Of course, medial pterygoid you can't palpate. Preauricular palpation and an intraauricular palpation of the joint. Look for joint sounds. Look for signs of bruxism, like wearing away of the tooth or ridging of the tongue and the buccal mucosa. If it's going to be a TMD disorder, say a disc displacement with reduction, the patient has got pain, limitation of mouth opening, deviation of jaw to one side, a clicking sound, don't venture into aggressive treatment like an arthrocentesis or a surgical repositioning. TMD is always best managed with conservative therapy, with physical exercises, limitation of jaw movements. A very simple exercise, I'll just teach you one exercise. Suppose clinically you say it's an anterior disc displacement with reduction, which means that the disc is moving ahead of the condyle, getting stopped. The condyle has to overcome this obstruction and then complete its jaw movement. The patient will open for about 17 mm. There will be a click. The patient goes to the right or to the left and then completes the movement. This is typical of an anterior disc displacement with reduction. Just change the bite of the patient. Give her the exercise. Ask the patient to bite in an edge-to-edge position, or ask the patient to bring the lower jaw forward. In this position, ask the patient to open and close. You will find on the chair, the clicking sound is gone, the deviation is gone, the pain is gone. So put the patient on this exercise, about 10 repetitions 3 times a day, just to reposition the condyle and the disc. Ask the patient to go on a soft diet. If there is a parafunctional habits, control it. Sleeping posture is very, very important. Most of these patients, if you take a history, they have the habit of sleeping on the side where they have the pain, either the left or the right. They don't say it to us because we don't ask them. The fault is not with them. The fault is with us that we don't do a good examination. So change the sleeping pattern. Majority of the problem is gone. If you want medication, start with topical anti-inflammatory with warm fermentation. Then go for milder analgesics. Then go for severe analgesics if required. Don't immediately go into tricyclic antidepressants for a pediatric patient. Manage it conservatively. So to conclude my presentation, yes, pediatric oral medicine cases or lesions are unique and they are different. They progress at a much faster rate, but healing is also quite good enough. Early diagnosis is required. Know what not to do before you know or before you do anything. Decision biopsy is a tricky situation because psychologically the child can get affected. It's going to be a surgical intervention, especially like an OFG. It's going to be a disfigurement. Take it on a case-to-case basis. Remember, pediatric malignancies are